functional and female section of urology of USI. So we have a very interesting topic for this session, that is urodynamics. Though it looks a little confusing for the postgraduates, and the session is planned in such a way that all the topics or subtopics of urodynamics are cleared by our learned faculty. So before I ask Dr. Anita Patel, Madam, to start, I request Dr. Uttam Mete, Honorary Secretary of USI, to give opening remarks.
Thank you, Dr. Surya, and thank you, Dr. Anita and Siri Siende, sir. Thank you all the faculty members. Good evening and a warm welcome to this live webinar. As you have seen from this scientific program, basically we are going to revisit.
Not hearing. Turn up volume.
Can't hear?
Yeah, now I can hear you.
Then I'll just increase. I think it's okay now. Sir, am I audible now?
Yes, sir. Very much audible.
So, good evening, everybody. On behalf of Urological Society of India, I extend my warm welcome to this webinar. And as you see from the scientific program, we have a very experienced faculty, and I thank on behalf of USA to all of them for making some time available for teaching our students, as well as even the consultants like me. And I don't have any agitation that there's no age of not learning. You can learn every time. So the basic thing is, so this webinar is to revisit our fundamentals, what I can see. So starting from the instrument equipments to all the tracing, and as you all know that urodynamics is not only reading about the tracing. We should know how to generate the trace and how to apply those traces. And I can say urodynamics is the stethoscope of functional urology. So without that, it is very difficult to diagnose so many cases of complex voiding symptoms or neurourology or any other intravesical obstruction, everything. So it is a part and parcel of all urologists. Majority of us are general urologists practicing in India. So everybody should know all these things. And I'm sure today's deliberations will, generate a lot of discussions, and it will help everybody. With these few remarks, I thank again all the faculty members for joining today. And of course, all the members will be listening to these webinars. Thank you. Jai Hind.
Thank you. Thank you, sir. So for all those who are joining through the e-learning platform, you can post the questions in the same chat box of the e-learning platform. So I will ask the questions to the faculty. Once again, I welcome all the faculty, Dr. Sarika, Dr. Siddharth, Dr. Nikhil, Dr. Swarnendu Mandal, Dr. Sirish Shandesar, and Dr. Neeraj Kumar for taking their valuable time and teaching the postgraduates and fellow urologists on this subject. So now I request Dr. Anita Patel, Madam, to take over the proceedings. Yes,
Thank you so much, Dr. Surya Prakash. Before we start, may I just request Dr. Yande to give some introductory remarks, and then I will start with my first talk. Shirish, over to you.
Am I heard there? Yeah.
Yes, Shirish. Nice and loud.
Yeah, thank you, Anita. I think I welcome all the members, and this is something which we all had to do at some stage. We've been talking about it for a long time, that we could do practical aspects of urodynamics and explain this to our junior colleagues as well as to each other, make sure that we're doing it the right way, we're interpreting it the right way, we're all using the right terms, we are all using the right methods of doing it. And urodynamic in a way is a propagation of a new science to all the people. So I think I must congratulate our society to allow us to do this, and this has been a fairly long session, but we all have to chip in our own way, and I hope we will be able to come out with some enlightening output towards the end. Thank you.
Thank you so much, Dr. Shirish. And before I start sharing my screen, we've tried to divide the topic into some very simple bold headings. So I'll start with the overview, which kind of gives something like a buffet of what urodynamics is all about, with little reference to the history and when it all started, etc., and what, when, why, and how. And thereafter, each aspect of UDS is individually um, uh, described and discussed by individual speakers, right from non-invasive to invasive urodynamics. And in the end, I thought we could collectively take questions. Each speaker will give information, keeping in mind to make it very relevant to day-to-day urology. So without any further ado, I'm going to start sharing my screen. And thank you so much, ISU and USI, to give us the opportunity to host this webinar jointly with all of you. Thank you so much. So I'm going to talk about basic principles of urodynamics, and I'm going to try and give an overview of that. I hope my slides are seen. Can somebody just indicate?
Yes,
Yes,
ma'am.
ma'am. Same.
Lovely.
Yes,
Lovely.
very much.
So before we talk about urodynamics, I think something very simple, which I want all the postgraduates to remember. And this diagram in a nutshell shows everything about the neurological aspects of lower urinary tract. So we know that sympathetics help us store, and they leave the spinal cord from T10 to L2, which means the actual vertebral level is way higher, roughly something like T6. We know that parasympathetics are responsible for emptying, that is to pass urine or peeing, and the relevant spinal dermatomes for the same would be 234, S234. The sympathetic helps us store. So the two autonomic systems have opposing functions. The external striated sphincter is the only somatic component of controlling the urine, which is again S234. The reflex center is at S234, but it is actually modulated by pontine micturition center. The two should not be confused with each other. And the higher central, which is so very uniquely human, is the frontal lobe, which helps us remain socially continent. What is urodynamics and what should you tell the patient? What should the patient expect? So basically, it is a test to evaluate function of the lower urinary tract, both during the storage and voiding phase. And in today's day and age, it is computer assisted for obvious reasons. And we measure both the vesical and abdominal pressures with the help of catheters. And the information is indicated by the patient, various sensations which are entered in the computer by the person who's doing the test. The basic principle is to measure the detrusor pressure indirectly by subtracting total vesical pressure, and abdominal pressure is subtracted from vesical pressure because we know detrusor pressure cannot be measured directly. The test takes hardly 30 minutes, done on an OPD basis, and of course is performed in men, women, and children. The normal urinary bladder has two functions, storing it and emptying it, and it does both of that at low pressure with full awareness. When we pass urine, the first event in micturition is opening of external sphincter. And lot of urodynamics gives, depends heavily on us understanding this simple act. So if external sphincter does not open, the act of urination cannot start. And then, of course, the detrusor contracts and the bladder neck opens. Once the bladder neck opens, it's impossible to defer micturition. And it's important to know some pediatric normal behavioral patterns, as to most children are dry during the daytime by the age of 3 and nighttime by the age of 5. The initial urination is, of course, entirely reflexly, but later on the child develops conscious control, and any variation from this requires proper evaluation of the children. So when did we start urodynamics as a concept? And in fact, if you look at Campbell's textbook, it takes us back to 1880s, where very cumbersome instruments were used to measure basic pressures and volumes in the bladder. But David Melvin Davis coined the term urodynamics, and he was the first one to use that and describe that in Journal of Urology in 1962. Post mid 80s, 1985 onwards, we started getting involvement of computers with pretty graphs. And now all of us are familiar with the way the urodynamics is done with complex tubes connected to a computer, which seems to make our life so easy. The broad indications I have told here, but I'm sure my individual speakers will be talking about these, so let's not spend time talking about that. Non-invasive urodynamics, again, Dr. Sarika has a talk dedicated to that, but I'm simply going to show you the hardware of non-invasive urodynamics, and that is the flow meter. And the flow meter most commonly used is the one at the bottom, which is the weighted transducer flow meter. That means the weight of urine which falls in this container is measured by the weighing scale at the bottom, which is connected to a computer and shown on the screen in the form of a voiding curve with the help of a software. However, this does have certain artifacts. If our feet accidentally touch the vessel which is on the weighing transducer, or if the patient's leg slightly touches the entire apparatus, you can get an artifact. As against that, a more robust flow meter is the one where a disc is rotating at the bottom. That's the one that I have shown you at the top. On top of this, a funnel is kept. And this is the most robust flow meter, which gives hardly any artifacts. And the speed required, this energy required by the machine to keep the disk rotating at a fixed speed is actually transferred to the computer screen with the help of a software. That means if the urine is flowing on the machine at a very fast speed, or rather a large volume all of a sudden, then the disk requires more energy to keep or to maintain its speed. And this machine has very few artifacts. Some pre-requirements, and that is the patient should be comfortably full, and we must explain the test to the patient. Having spoken about the hardware of non-invasive urodynamics, which is the flow meter, now we are looking at invasive urodynamics. What I'm showing here is the infusion pump, and there is a specialized tube here. Sorry. There is a specialized tube here, which is called damping tube. It is made of silicone, and the rotating infusion pump rotates in a direction which facilitates the fluid from the connected bottle to enter the patient's body at a fixed speed. And this speed can be changed with the help of our computer software. The pressure transducers are named in the machine as P1, P2, P3, depending on how many transducers do you have. And they have to be flushed and made free from any air bubble. And a simple three-way tap helps us do that. Right now, the flushing syringe is actually simply connected, but the transducer and the non-kinkable manometry tubings are in line. That means the transducer is actually sensing the input coming from these lines. When we flush it, you can see the three-way tap is now changed. That means now the fluid is being used to flush the non-kinkable pressure tubing to remove any air bubbles. And in some of the machines, we have this little gadget at the bottom to get rid of any air bubbles or any excess fluid, etc., etc. And we balance the transducer to patient symphysis pubis, and that is considered as our zero by keeping the tube open to atmospheric pressure, the most important step. That means we zero balance it before connecting it to the patient's body. And that is something which should be understood by us. So when we're looking at invasive urodynamics, most systems use water-filled catheters. The air-charged catheters are not there in most systems used by urologists. It is a good practice to use two catheters. However, you can use a dual lumen if there is a child and you want a very thin single catheter. We, of course, need a tube inserted from the rectum. The tubes must be fixed securely. And these are the tubes that we use. Simple infant feeding tube. This is a double lumen. I'm trying to show all the hardware of urodynamics. And this is the rectal tube which we use, which we make with the help of a finger stall, which is fixed on top of an infant feeding tube, and a tiny hole is made at the top to allow the air bubbles to escape, number one, and also to prevent fecal matter from blocking the tube so that the pressure measurement is correct. We do EMG in some patients, two types of electrodes, the adhesive electrode or a needle electrode. The needle electrode, of course, is invasive and the needle needs to be sterile, whereas adhesive electrodes are disposable, easy to use, and we will, of course, use a new electrode for every patient. And needless to say, we need gloves, we need some sterilizing solution, and of course, we need xylocaine gel prior to inserting the catheter. This is a close-up of the EMG electrode. We also need a grounding electrode, which is shown at the bottom, and that is for earthing. I have also tried to show an EMG electrode which I used to use years ago, and that is an anal plug electrode, a little cumbersome to use and not very comfortable to the patient. Most comfortable electrodes are these, which is the patch electrodes. Most accurate is the needle, but of course it is invasive, and in a neurologically intact patient with intact perineal and perianal sensation, this can be a bit uncomfortable. Urodynamics should be considered as a strictly a sterile procedure. So a sterile tray with disposable needles, disposable gloves, and a sheet to cover the patient, any gauze pieces, and a little container in case you want to flush the catheters, etc., etc. How do we start the test? So simple things: make sure that correct name and address is entered. Check if any antibiotic is required. Check the infusion pump correctly. Make sure you connect the abdominal to the abdominal transducer and vesicle to the vesicle transducer. I have seen this interchange so many times and operator not being aware of it, which is a disaster. As I said, flush any air bubbles, zero balance correctly to atmospheric pressure before connecting it to the patient's body. Before doing UDS, there is a certain checklist. So if you're offering a referral service, then check who is referred and what is the urological complaint and what is the urodynamic question to which you're seeking the answer. With urodynamics, let us remember we check both storage and voiding lower urinary tract symptoms. So if there is a patient with a catheter, then initial free flow cannot be done. If he's not with the catheter, can the free flow be done? That means, does he void on command? If he has leak, has the leak been characterized clinically? Is it urge leak? Is it SUI? Are we suspecting anything neurological? Is there history of UTI? Because that means, should I be prepared with pre-procedure antibiotic? And is this the first time they're having the test? Because I'm going to counsel them correctly. Prior to any UDS, three important things: a simple urine report, routine and micro, and a culture test whenever it is relevant. Ideal to have a sonography for post-void residual urine for those without a catheter. And if patients have storage symptoms, then is there any bladder diary? Is there a previous urodynamic report? And in which case you will use that for comparison. All these are absolute must prior to doing any urodynamic. Especially for a child, I would look for additional reports as I have mentioned here. These are normal flowmetry graphs and they must be used for reference. Sarika will talk about this. Simple do's and don'ts. During the test, the patient should be made to cough every 50 mL to check that the cough transmission is correct. The patient should inform voluntarily the bladder sensation, and we should not keep on asking. Otherwise, just because we are asking, patient says that yes, peshab aa raha hai. So best to let the patient volunteer the information. Please respect patient's privacy and dignity and give adequate privacy, and also support the tubes, because if the tube slips out, and it will do so in the most important patient where voiding parameters are so vital, that would mean that you will have to redo the whole thing. Always match the clinical data and check if the test needs repeating. However, especially in pediatric patients, the best attempt is the first attempt. Children don't take to UDS very nicely and they don't like a rectal catheter. So please keep that in mind. And if the patient requires an antibiotic, that decision should be taken based on clinical parameters. Fill speed, about which Dr. Siddharth Kalra will speak, but ideal to have physiological fill speed. But ICS originally had three speeds: slow, medium, and rapid. And these are standard urodynamic indicators which should be used to describe the bladder sensation. It's very important that we use correct terminologies which are actually told by ICS. So the language that we use must be common. You cannot just use different language. You cannot say instability when now we are using the word overactivity, etc. I'm going to jump this because Dr. Kalra is going to talk about it. And this is the way we show a standard graph. Cough repeatedly seen during the test. The sensations are described at the bottom, and the voiding phase will be described in detail in somebody here who is obviously high pressure voider. Somebody regularly doing urodynamics should be very familiar with these plots and these terms. ICS has described bladder outlet obstruction index. All of us are familiar with this term, and bladder contractility index. And these figures tell us whether somebody is obstructed, equivocal, or unobstructed, depending on if BOOI number is more than 40. And now we have an additional category where if bladder outlet obstruction index is more than 80, the person is severely obstructed. And if somebody has bladder contractility index less than 50, he has got very weak detrusor. So these terms have to be very clear. What about video? There are definite advantages. However, video is cumbersome. There is a certain costing involved in video, and a specific type of room is required. There is more manpower required. You must have adequate training to interpret the X-ray, and there is a risk of radiation exposure. The procedure takes that much longer. However, whenever required, you should have video study available. So in this graph, there is a video UDS in a child who was a dysfunctional voider. She was leaking. Sorry for the inverted image, but this is a classic spinning top. In this child, with every overactivity, she was actually leaking urine, and she was a classic dysfunctional voider. We can also use that in somebody who's having recurrent SUI. This was one of my patients where on a cough, on fluoroscopy screen, she was actually profusely leaking, and I had placed a sling which was wrongly placed. It was distal urethra. I should have actually placed it at the bladder neck because here an intrinsic sphincter defect was an issue. So video does give important information. In academic scenario, ambulatory urodynamic can be done, which is somewhat similar to Holter monitoring, where catheters are placed, secured, and fixed to an ambulatory recorder, and patient keeps the catheters and the gadgets on for 24 hours, and continuously the recording happens. And this is definitely useful for conditions such as occult overactive bladder or occult neuropathic bladder. Regarding urethral pressure profile, we don't do it regularly, but to me it is more relevant in the last paragraph I have mentioned. It's not so much static UPP, but micturition urethral pressure profile, which is very important in select situations. Boys with PU valves, neuropaths with DST, or in women where suspected non-relaxing outlet is expected, and that is where a high pressure zone will be seen in the urethra proximal to the level of obstruction. Leak point pressure, Dr. Khattar will be talking about. The important message I would like to give it is not the absolute value of leak point pressure, but the entire clinical scenario which should be matched with the additional information that leak point pressure tells us. If you're starting new with UDS, some of the important things is what kind of machine. Is your setup private? Is it a tertiary referral center? Do you want a basic machine or high-tech machine? And also, a lot of these parts of UDS require fancy cost. It's not just the cost of the machine. You need a room, you need electrical supply with a stabilizer, CM if a video is to be done, continuous water supply, salary for staff, stationery, medical consumables, sterilization of trays, and not to forget annual maintenance contract. All of this has to be factored in when you're costing urodynamic services. So to conclude, no content should be read without a context. Ask a question, look for answers in non-invasive tests, and reserve invasive UDS only when it is required. Customize the text. Remember, there could be strict quality control. And a repeat test can always be considered if your test is not showing what you're looking for. Remember, pre-UDS correct evaluation will give us better interpretation of UDS. We should not be in a race to somehow do the test. Please make sure you evaluate the patients correctly pre-urodynamics. I'm going to stop sharing my screen. Thank you so much. And
Very well.
Thank you,
Anita,
madam.
I wish there was a provision for applause on webinars.
how sweet.
But unfortunately, we don't seem to have it. But you could have got a great round of applause
you so much.
after a wonderful summarization of the entire
I
test.
think
Thank
we'll
you
move
so
to
much.
Dr. Sarika,
Okay,
should we?
right.
Yeah,
Right.
thank you so much.
Let's move ahead. Thank you. Right.
Sarika, you can share your screen. Thank you so much.
Sarika,
Yes, sir. Yes, sir.
please. Yeah.
Good evening, everyone. Hello. Good evening, everyone. Am I audible?
Yeah, go ahead.
Yeah. Thank you very much for giving me this opportunity. So today my topic is non-invasive UDS. That means that it is a very much valuable adjunct to conventional UDS, where the patient has a very greatest comfort and it gives us the basic workup of lower urinary tract symptoms. I am covering in my talk three important aspects of this non-invasive UDS are the bladder diary, uroflowmetry, and post-word residual urine. So bladder diary. Bladder diary is a voiding diary, or some tell as a frequency volume chart, or a bladder diary of a voiding diary. Is a patient who wrote as in their handwriting with the fluid intake, voiding frequency, voided volume, urgency episodes, and leak episodes. Typically, it takes over 3 to 7 days, and it is considered the gold standard in non-invasive tool for objectively assessing the lower urinary tract symptoms to formal urodynamic studies. So what is the structure of bladder diary? Each column captures a discrete data point essential for accurate symptom characterization. It includes the time, clock time of each void volume, voided volume measured using the calibrated jug, urgency grade like using a validated scale of 0 to 4, leakage episode, is there any leakage, yes or no, and estimated amount also, fluid intake type and volume, pad use number plus weight if required, and sleep periods to distinguish nocturnal from diurnal voids. So key parameters derived from the diary are like daytime frequency, a number of voids in waking hours. It should be less than 8 as a normal reference. Nocturia, voids after sleeping and before rising, less than or equal to 1 per night. Maximum voided volume, that is the largest single void, and it can be a 300 to 600 ml. Mean voided volume we can calculate with total volume divided by number of voids, and it can be a 250 to 350 ml. Functional bladder capacity approximated by maximum voided volume. Total fluid intake, so it can be the sum of recorded all in body, fluid intake in a 24 hours. 24-hour urine output, sum of all voids. If it is more than 2.8 liters in a day, it can be a polyuria. Nocturnal urine volume, all voids from sleep onset to first morning void. And nocturnal polyuria index, that gives us, if it is more than 33%, it tells us it's a patient is having a nocturia. So clinical significance of bladder diary are it establishes the baseline symptoms. So it gives us objective documentation before initiating any treatment, either behavioral, pharmacological or surgical treatment. It differentiates the LUT subtypes like frequency versus urgency or nocturia, or incontinence like it's a stress or urge. It guides the diagnosis also. If patient is voiding with small volume with urgency, it can be detrusor overactivity. Is it a nocturnal polyuria or global polyuria or a reduced bladder capacity. It also gives us monitor treatment response and promotes the patient engagement, because it is done by patient himself. They have a self-awareness, and they help themselves for behavioral modification. So interpretation framework, is there a polyuria? We can come to know it's a global polyuria. So if it is more than 2.8 liters, we require to investigate for diabetes mellitus or polydipsia, or nocturnal polyuria required OSA workup. If the bladder capacity is normal or it's reduced, if the maximum volume voided volume is less than 200, suggestive of detrusor overactivity or other interstitial cystitis type of changes. If the urgency pattern can tell us it's the high urgency, grade 3 to 4, plus small volume, it's suggestive of overactive bladder. Leakage with urgency, urinary incontinence. If it is a nocturia pattern, also can tell us it's a nocturnal polyuria or reduced capacity, or it's because of the obstructive sleep apnea. Sometimes we can also come to know that with the fluid intake audit, patient is taking more than 3 liters of fluid. That means because of excessive fluid, they have a multiple times they need to go. So fluid restriction will help them. Are they taking more like heavy caffeine or alcohol? That will also, we can give a counseling for the bladder irritant avoidance. And evening fluid intake also, we can tell if patient is having more evening intake of liquids. So practical tips, minimum 3 consecutive days is important. The 7 days will hardly add on the marginal gain in the most patients. So 3 days is important. We should provide a patient with calibrated measuring jug, because many of the times they said I avoided small volume, I avoided large volume. We can't rely on their quantity. Digital apps improve the compliance, and review with the patient, discuss the diary and follow-up also help us to show them that how much improvement they gain after their behavioral changes or their treatment plan. Uroflowmetry. It measures the rate of urinary flow with the voluntary voiding, and it is expressed in milliliter per second, and it doesn't require any catheterization or intubation, and patient had a good comfort. It serves as a screening gateway to the formal urodynamic studies. Types of uroflowmeter already madam has discussed, and most commonly we use is a rotating disc uroflowmeter, capacitant dipsmeter, gravimetric, and ultrasound based. So now we come to know the key parameters what we obtain from the uroflowmetry. So valid interpretation requires a voided volume of more than equal to 150 ml. So if patient has voided less than 150 ml, we should not consider it, because the Qmax is unreliable and should be the study should be repeated. So these parameters will come to know through the uroflowmetry. Qmax in normal male and female, and what is the clinical significance. So Qmax is more than equal to 15 in normal male, and more than equal to 20 is normal for the female. Q average is equal to 8 to 12 in male and 10 to 14 in female. Voided volume should be more than 150 ml. Time to Qmax should be less than 1/3 of total voided volume. If it is prolonged, that means a poor, that gives us a significance of the poor detrusor contractility. Voiding time should be less than 40 seconds, and for female less than 30 seconds. Prolonged timings means it's outflow obstruction or weak detrusor. Flow time as equal to voiding time, and post-fluid acidular urine should be considered after each uroflowmetry by the bladder scan. These are the flow curve patterns which are the diagnostic key. We found in our day-to-day practice with this kind of curves, like the bell-shaped curve, that is a normal, and it has a smooth single peak with a rapid gradual fall. That means the coordinated detrusor contraction with relaxed sphincter. We found that plateau or box shape pattern. Many of the times we heard that box pattern, that is suggestive of bladder outlet obstruction. That means the low flat curve, and Qmax barely above the Q average. This is classic with BPH or urethral stricture. Staccato, that is usually with a jaw shape without complete cessation of the voiding, but it's suggestive of overactive sphincter, and most of the times in neurogenic patients. Intermittent means patient have a straining or weak detrusor. Flow repeatedly halts. It comes down and it's again rising, comes down and again rising. That is means the patient is using abdominal straining, and usually seen in detrusor underactivity or intermittent sphincter contraction. Tower shaped curve, that is usually comes with the very high Qmax with rapid fall, seen in stress urinary incontinence patient, and it's suggestive of poor urethral resistance. Prolonged flow suggestive of urethral stricture. Sometimes many of the patients with terminal rebel, they have a Qmax, then it's slowly it's coming down to the baseline. That is called a prolonged tail shape curve. So, importance of uroflowmetry. Why it is invaluable? Because it's a non-invasive, no catheter, no pain or no infection risk. Physiological voiding in privacy. Low cost and quick, 5 to 10 minutes of test and fraction of full UDS cost. Reproducible, we can repeat if required on each visit, and it's suggestive of objective data rather than relying on the IPSS like type of subjective score. This gives us the objective data. And application by population in each and every patient we can use, like males for rule out the BPH and blood screening, or post TURP whole patients, female patients, children also, and neurogenic patients also. There are some limitations, like uroflowmetry cannot differentiate between bladder outlet obstruction and detrusor underactivity, because both produce a low Qmax. It provides no pressure data. The pressure flow study is required for differentiation. So when to proceed the full invasive UDS? When patient having a etiology is unclear, like low Qmax, high PVR, but etiology is unclear. Preoperative BO surgery in equivocal cases, neurogenic bladder, post-operative voiding dysfunction, pediatric complexes, and failed empirical therapy. So it's a uroflowmetry, as we know, it's a non-invasive, while urodynamics requires a catheterization. Cost is low. In a 5 to 10 minutes study, flow rate and PVR and curve will come to know, but we can't differentiate on detrusor underactivity and BOO, and it's for screening. While urodynamics has a high cost, it requires a larger time, and but it can tell us the detrusor pressures, compliance, and detrusor sphincter dyssynergia type of thing, and also it can differentiate between the detrusor underactivity and bladder outlet obstruction, and it helps in complex and equivocal cases. Now we move to the post-void residual urine. So PVR is the volume of urine remaining after the bladder after the emptying of the bladder, and under normal physiological condition the bladder empties almost everything and there is no post-void residual urine. So we usually use the ultrasound measurement for post-void residual urine measurement, and that is applies as a Prolet ellipsoid formula. It measures with the volume is equal to length, width, and height into 0.52. But nowadays it's a portable bladder scanners are available which calculate the automatic calculation, and bedside assessment becomes feasible. It accurate measurement requires imaging within the 10 to 15 minutes of void. If it is a prolonged, then we can't consider as a accurate measurement of post-void residual urine. So usually patient comes with a less than 50 ml, we can consider as a normal. 50 to 190 ml it's a gray zone, and more than 200 ml consider as a abnormal. So clinical significance of elevated PVR. An elevated PVR signals one of the two fundamental pathophysiology. It can be because of the outlet obstruction or detrusor underactivity. But we can't predict it. It requires a full urodynamic evaluation. So why PVR is significant? Because it guides the catheterization decision, determines whether CIC or indwelling catheterization is clinically warranted to protect the upper urinary tract, identifies upper tract risk, like chronic high volume retention increases the risk of hydronephrosis and renal impairment. It guides us the safe prescribing of anticholinergics and beta-3 agonist in the patient who comes with the OAB symptoms, and it will also monitor the treatment response, like patients who are on alpha blockers. We can do the serial PVR to track the efficacy of alpha blockers or impact of OAB therapy on bladder emptying over the time. So when to measure PVR routinely? So whenever the patient comes with the LUTS symptoms, initial assessment in man and woman presenting with lower urinary tract symptoms require the PVR measurement before starting the OAB therapy, as well as the neurogenic bladder and post pelvic surgery. And patients, old age patients who are coming with recurrent UTIs, many of the times urinary stresses from incomplete emptying is a cause for the recurrent UTIs. So we can help them to empty their bladder with either medication or any other way, like self catheterization and all, and that can reduce the risk of recurrent infections. So, but there are limitation of measuring the post-residual urine also. Like in the obesity, sometimes it can overestimate pelvic masses, and fibroids can underestimate with mistaken of bladder fluid. And timing should be within the 10 to 15 minutes. If it is more, then it will overestimate the residual urine. And yeah, definitely intra-individual variability is there, and single PVR reading cannot be considered as a high post-residual urine, because it may affect because of the hydration status, patient anxiety, voided volume also. So it requires at least two separate measurement to consider is for the management decision. Thank you.
Thank you, Dr. Sarika.
I wish to mention
There's some echo coming. I think somebody has logged from two
a bladder
devices.
scanner, a handheld bladder scanner should be a part of all urodynamic laboratories. Such a useful and functionally powerful instrument that if you're given some indications of doing a post-word residue measurement, but I think, Sarika, it could be every uroflowmeter, if it is available, we should do it, because it gives you a different interpretation of uroflow, and I think it does make a huge difference that you have a handheld bladder scanner as a part of armamentarium of a urodynamic laboratory. Okay, please go ahead.
Yeah, shall we move on to the next topic? Yes, Dr.
Yes, sir. Am I audible, sir?
Yeah. Siddharth, yes.
Sir, I'm audible?
Yes, Siddharth, you are.
Yes, Siddharth. Please
So, thank you for the opportunity. So, basically, I will be talking about CMG. 1 minute. Just I want to put this down. Okay. So, CMG is primarily a way of measuring the pressure flow dynamics with the help of a urodynamic machine to understand what is the voiding dysfunction going on with the patient. A good urodynamic practice gives three clear elements. Basically, you have to have a clear indication and a test selection, do a precise measurement of the data, and a critical reporting of the events. Who should be doing urodynamics? Either a urologist or a urodynamic technician. So there are various thoughts about it. I feel that the clinician who is treating the patient or diagnosing the problem, if he is directly connected during the study, it always gives a better result. Although a very trained technician can also do a good study. Now, when you start a study, what are the critical things you should understand? So before doing the study, you should have an idea about 4 critical factors about a patient. What is the voiding dysfunction like? Whether there is any incontinence, whether there is any upper tract problems, what is the quality of life? And then you devise your study question. So there is a small example, say a 30-year-old female with voiding LUTS, with a poor uroflow, what can be the urodynamic question? Whether she has a bladder outlet obstruction or an underactive bladder. So what do you look for in a study, or what do you want to see? You want to see the reducer contraction, what is the flow, and subsequently how you can customize this study by adding an EMG or a video to further give what type of obstruction it is. Not just bladder outlet obstruction, but whether it is at the bladder neck, is at the sphincter. So this is your initial starting point. Now already it has been discussed what to do prior to it. So what are the main indications of urodynamic study? So absolute indication is anybody having a neurogenic bladder, you have to do a urodynamic study. I feel female voiding dysfunction is almost impossible to diagnose or categorize without a urodynamic study, and video is an essential part of it. I will come to male non-neurogenic LUTS in the next slide. Besides that, refractory overactive bladder, complicated SUI, and there are many other indications. In male LUTS, I would say the main indication, if you're planning an invasive treatment, whether the patient is very young or very old, whether there is a high residue, or there is a previous failed intervention, these are the main indications. Now, this is the ICS information leaflet. So it gives us what to explain the patient before the study. First is you have to explain the test. You have to explain what is going to go in during the test. You have to make aware of the patient to be as comfortable and as natural as she can be, while she has to reproduce what she does in real life. That is the bottom line of doing a neurodynamic test. And of course, you have to tell her about the discomfort afterwards and whatever health she has to take care. We have to take consent, all those things already discussed. Now, this is our urodynamic setup at our center. So we do video aerodynamics for every case. So this is the C-arm. This is the radiolucent sonesta chair. And this is the machine which records all the thing. And this is the C-arm screen. So some point is discussed about catheter, but I will also explain something. So there are three types of catheter: water charge catheter, air charge catheter, and microtip catheter. I have personal experience with doing both water charge and air charge. The water charge we primarily use now in India. Air charge is costly. The prime difference between water charge and air charge is water charge is dependent on the hydrostatic pressure. Like there is a water column, so there are problems of air coming in. Although the good thing about water charge is the reproducibility of the results is much more. On the contrary, air charge catheter are very easy to do, very fast urodynamics. You don't need to do any flushing, or there is no, as such, no water column in that. And there is a difference of zeroing among these two catheter I will discuss in the subsequent video. But air charge catheter, the only drawback which has been seen is that the pressure recorded by air charge catheter are much more than water charge catheter for the same patient profile, same patient per se. So the standardization of these two studies is still not there. Two type of catheter. So these are the different catheter already discussed. Only thing I want to mention is double lumen catheter. That is a 6 French catheter, which is very commonly used. But you need to understand that when you use a double lumen catheter, when you give a very fast fill may not be able to go through this such a narrow catheter. So you're filling, say you fill 600 ml, and when you void, it might come as 400 ml. So you have to have an understanding of that. And very fast fill with a narrow lumen catheter may not be possible. And this is the EMG electrodes. We use surface EMG electrodes. Now, coming to the position, it is very important to understand what position you are doing the study. In males, what is the physiological voiding position? That should be the position of the urodynamic study. So in females, we do sitting position. Males, we do standing position. But a lot of Indian females void squatting. So sometimes we have to change them to squatting if they're not able to void sitting to make them as physiological as possible. Besides that, there are certain other positions in different scenarios. If you want to check for leak, you have to do sometimes standing, squatting. Then in spinal cord injury, quadriplegic patient, you have to do lying down position. So these are some intricacies you have to know. This is the basic setup. You put a catheter in the bladder. You put a catheter in the vagina in females or in the rectum in males. We prefer vagina in females, very comfortable and quick to do. And then subsequently disconnected to the machine, and then recordings are there. I will explain further. So this concept of zeroing and charging. So this is important to understand, especially in the scenario of water charge catheters and why we do it. So you understand there is a bladder, the catheter going to the bladder, which is connected to a transducer, and there is a stopcock connected to the atmosphere. You will have a video subsequently. So we always do zeroing at the level of pubic symphysis. But why we do zeroing? First of all, because we want to reproduce certain amount of similarity when the study is done for the same patient in different setup, like one center or the center. So you create a zeroing at a pubic symphysis, and subsequently you charge the patient, or you connect the transducer to the abdomen and record some intra-abdominal pressure. A urodynamic trace which is showing absolutely zero pressure at the initial aspect is not correct, because there is always some intra-abdominal pressure, especially in sitting it can be 20, standing it can be 30, supine it can be 10 or 5. So you have to understand that. So this is the basic video showing how to put the catheters. Fixing the catheter is a pretty critical event, because if you don't fix the catheter correctly and your catheter comes out, then the study is of no use. So you fix it in such a way that it is comfortable and it also allows the patient to void well. Now, this is the concept of, first we remove all the air through the lines. So right now there is direct connectivity between the transducer and the catheter, which is to be connected to the patient, the tube. After connecting that, now we open the stop clock. I will just show you. We open the stop to the atmosphere. The transducer is open to the atmosphere, and that is at the level of pubic symphysis, and that is where we do zeroing. So you will see the trace to understand what is happening in the zeroing phase. So, oh, sorry. 1 minute. I was expecting that to happen. Sorry, it's just hung a little. Sorry, 1 minute, I'll just come again. Hello. Ah,
Siddharth, do you want to stop sharing and restart?
I'm ready, ma'am. Just come. Sorry, sir. Sorry. Just hang. No, there is some problem.
So
Can
how
you see,
about,
ma'am?
yeah, we can see your screen, but as
Okay,
I
I
understand,
continue.
your PowerPoint is going through some troubleshooting. Yeah, of course
Now
we
it's
can
okay.
see now.
Okay, Siddharth,
Yes,
are
of
you
course
okay?
we can see.
Because that video got stuck. Sorry.
No
I'll start
problem.
again.
No problem. No problems.
This is slow because it gets. So I was telling you about the fixation and the zeroing and the charging. So I will show you through the trace what happens in the trace when you do the zeroing and the charging to understand what you have to do. So after fixing the catheter, subsequently we first flush the line to clear the air. After that, once the catheter is connected to the patient, we do zeroing to the atmosphere. The transducer is zero to the atmosphere by changing the stop clock. And it will just come. So now we are zeroing, we are connecting the transducer towards the atmosphere, and then we press the zero button in the machine. I will show you that later on. And once we have zeroed, so here, once we flush, there is a rise in pressure, and there it is, the zeroing is done here. This is the all zero. Then subsequent to it, we charge the catheter, we charge the transducer to the patient. We connect the transducer to the patient side, and then automatically it records the pressures in the blood, which is subsequently raised. So these are the pressures recorded in the bladder, which are never zero. So that is the bottom line of zeroing and charging, which is very critical to get a standardized study across various setups. Now, regarding filling, so during filling phase, first thing is when you're filling, you have to set your filling according to the study. If there's a case of overactive bladder, or for that matter, neurogenic bladder, you go with a slow fill. So historically, there are these fill rates. Physiological fill rate is body weight divided by 4. So you have to adjust your filling rate according to the study. So how do a urodynamic trace look like? So what are the components of a urodynamic trace? So first is, although ICS say abdomen should be the first trace, but in our setup, we do vesicle as the first trace, which is more understandable because vesicle minus abdomen is a PDET. So first is vesicle trace, second is abdominal trace, third is a detrusor trace, fourth is the infusion trace, how much is the volume filled, and finally there is the voiding phase and the voided volume phase. Of course, there is EMG also. In this trace, it is not there. Now, when you are seeing a trace, the most important thing you have to understand is whether this trace is good or bad. Means to say whether it is equalized well or zeroed well. So if you see here, it is pretty good trace in the sense that it is not zero at the initial aspect. At the same time, when you are asking the patient to cough, there is a regular coughing done, like ma'am told 50 ml per cough. So we have been coughing regularly, which is marked here. So it is showing pretty good understanding of that. Now, beyond that, what are the different parameters of filling, which is the first sensation, first desire, strong desire, urgency, and maximal systematic capacity. So all that is marked here. This is the first desire, first sensation, first desire, strong desire. Typically, it is simple to remember: 125, 250, 400, 500 to 600. Now, when you're doing a study, when you're starting the study, it is important to talk to the patient, make her understand what she might be feeling, and how do you ask these parameters. So suppose how I ask when you feel something in his bladder, possibly that is the first sensation. Second is when I want the patient, say if I ask the patient, can you give me a sample of urine if I want? And she said, yes, I can do that. That is somewhat first desire. Strong desire is something when she will normally go to toilet at home. If you are at home at this point, she will normally go. Urgency is that she will rush to toilet. And finally, there is a maximum systematic capacity. Now, other thing important to understand is these buttons, which are different for different machines to trace all these factors. And these important to understand is this parameter of 0 to 150. These are the scales which can be changed. And accordingly, we measure the trace. We will further see. So now coming to various things which we can find during filling. So first is detrusor overactivity. So detrusor overactivity can be phasic, idiopathic, or terminal detrusor overactivity. So phasic detrusor overactivity is high magnitude rise in detrusor pressure without any rise in abdominal pressure. And it is at regular interval, very high magnitude, typical of a neurogenic bladder. On the contrary, sporadic overactivity is found in overactive bladder. Also, we need to understand that not every urodynamic will manifest the overactivity of the overactive bladder patient. 50% patient may not show overactivity in the urodynamic trace. Similarly, terminal detrusor activity typical of BPH is seen where at the end of the fill, there is sudden rise in overactivity and culminates in a void. These typical patients, this type of overactivity improves after the surgery. Now, the second thing is of compliance. So what is compliance? There is a gradual rise in the P det with fill associated with no rise in P abdomen. It is typically found in neurogenic problems or where bladder is totally damaged. So this is the second filling finding we can find in filling phase. Then, like I talked about neurogenic detrusor activity, similarly in neurogenic bladder patients, it can be associated with detrusor sphincter dyssynergia. So it is very common belief by people, a lot of people, that detrusor sphincter dyssynergia is a finding of voiding phase. But it is not. It can be voiding. It can be filling also. During filling, if there is a detrusor activity associated with the increasing sphincteric activity, that reflects detrusor sphincter dyssynergia. When it is non-neurogenic, it is primarily voiding, that is dysfunctional voiding. And it is associated with the spinning top urethra, as discussed earlier. Now, it is very critical to understand sometimes during the fill, at the end of the fill, sometimes we find high pressures. P det end fill is, say, sometimes 20, 10, and we feel the compliance of the bladder is bad. But you always have to see whether the P abdomen is stable throughout the study or it was gradually falling. Because if P abdomen is falling, the P det is supposed to rise. So we should not always go by the readings of the software. We should see the trace and correlate with the clinical picture. Now, coming to disorder of stress incontinence, so we look for leak. Already leak point pressure will be discussed subsequently, so I'm not going into it. So it is by coughing, there is a leak. That is stress incontinence. When associated with detrusor overactivity, leak, it is detrusor overactivity incontinence. There are multiple levels of detrusor overactivity seen in this trace with leak. Similarly, detrusor leak point pressure is when the detrusor pressure rises to that extent without the presence of any overactivity or abdominal pressure, when it starts to leak. That is detrusor leak point pressure that we'll discuss subsequently. Now, cough-associated detrusor overactivity, typically seen in mixed incontinence female patients. Some scenarios due to urethral reflex. So typically, when the patient coughs, there is a leakage of urine in the urethra, which stimulates the detrusor, causing detrusor overactivity, culminating into a leak. So this is the very classical finding, and these patients generally improve with sling surgery. Now, coming to once you are finishing your filling phase and you're going to the voiding part of it, you need to understand whether your filling questions were answered simultaneously. Means you don't need to stop the study, but during the study itself, you need to understand whether filling questions were answered. There is no detrusor overactivity or urgency suddenly manifesting at the time of permission to void. Patient is a normal standing position or normal position to void, comfortable position to void, and when you give permission to void. One common mistake which I see people, especially my resident and other people doing, is when you are filling and when you are reaching to the point when you have to pass urine, you tell the patient to stop, wait, hold. I have to arrange certain things. I have to arrange CM, or I have to click on the screen and arrange that. Never do that, because see, somebody is developing an urge to void and you suddenly stop that patient to void. That urge will go away. So that void which he will do will not be represented. So in scenarios where you feel the patient might suddenly void, you tell the patient, when you feel like voiding, you go for it. Don't stop. You can stop the pump, you can screen, you can do anything subsequently, but don't stop the patient. Now, other problem which I've seen in a lot of reports which come from different centers, people have to understand what is detrusor contraction and what is just an artifactual rise in the detrusor trace. So a typically detrusor contraction or is a sustained curve, a contraction of a good magnitude. On the contrary, here also if you see, the software will record that P det at Qmax is 100. Here also it will record 100. But this is not a detrusor contraction. This is an artificial rise in the P det trace because of the mismatch of transmission between the P vesicle and the P abdomen. So some people will see the report, say, oh, P det is good, bladder outlet index is good, so this patient is obstructed. You have to really see the trace. Now coming to this third trace, if you see, there is abdominal straining, but at the same time, there is some amount of sustained contraction which is throughout. This is the case of underactive bladder. This is not totally hypocontractile bladder. So there is a detrusor contraction here. Now coming to the next point, when we are seeing the voiding phase, we are seeing the contraction, the flow, we have to calculate the bladder outlet index and the bladder contractile index, which gives us an idea of obstruction and underactivity. These are primarily for males. These don't put the bladder outlet index, these ones for females, which people generally calculate as soon as they ask if the female is obstructed or not. For females, the typical, the typical parameters which I use, which are very good, is if P det Qmax more than 20, flow less than 15 or 12, patient is obstructed. But I always prefer to do a fluoroscopy along because we do video, and fluoroscopy is actually must to diagnose female bladder outlet obstruction. You cannot diagnose PBNO or dysfunctional voiding or third thing without a fluoroscopic image. Now, one more thing which I very want to stress is regarding whenever you feel that patient is hypocontractile bladder or underactive bladder, means to say patient has not generated any great contraction, it's just training. Again, assess. See, if you label somebody hypocontractile or underactive, you label him that you don't have any treatment for life. But there are chances that patient might not have been comfortable, patient might not have generated a good contraction, or maybe patient is having catheter. So understand it, repeat the study before labeling anybody hypocontractile or underactive. And you will have, of course, other parameters to suggest it, but don't just do one void and say that, okay, this is it. Now, these are some of the female traces. This is just a trace of video dynamic of a female bladder outlet obstruction. This is the high P det, and this is the voided volume, and this is the fluoroscopic image. The advantage of video aerodynamics is that you get a synchronicity between the void which this patient is doing and what is the fluoroscopic image. If you do an MCU separately, these are two different studies. So you cannot correlate very well. So it will not give you the confidence to go and do a surgical intervention. So VUDS is very critical to do in female bladder outlet obstruction. So this is a trace of female bladder and dysfunctional voiding already discussed. Now, how do you report the study? So ICS has a template. So basically, you can have 5 C's of filling, 4 C's of empty. So we will discuss this 5 C's of filling first. So what are the sensation like? Are they absent, reduced, normal, increased? What is compliance like, normal or abnormal? We all know the formula of calculating that. Detrusor contraction, whether it's stable filling or there are detrusor overactivity present, associated incontinence, whether it is phasic, terminal. Then continence, whether patient has stress incontinence, detrusor overactivity incontinence, or no normal. Then finally the capacity, and if there is any detrusor leak point pressure, then you have to flag that also. During voiding, again 4 C's of contractility. How are the contraction? What is the BCI? What is the coordination like? If there is dysfunctional voiding or detrusor sphincter dyskinesia, whether patient is voiding completely or not, and if there is any obstruction, whether it is on the basis of bladder outlet index or other index, whether it's obstructed, equivocal or not. Now, to synthesize, when you write a report, first thing is whether the patient reproduce what she does in real life. If she has not got that feeling, that means the study is not good. So you need to do that. Then you have to mention about the filling phase finding, storage phase finding, any upper tract changes finding, like anything high P det or anything risk factors, whatever the limitation of the study, whether catheter came out or there were technical artifacts. So this is a typical report. Now, besides that, I would say artifacts, there is a topic on that. So I will stop here. Thank you. Hello? Hello?
Thank you so much, Siddharth. Would
Sorry,
you
sorry.
stop sharing the screen?
Oh,
Lovely.
yes, yes.
Yeah. Thank you
Sorry.
so much. Thank you so much.
One. Just, sorry. I just lost.
On to the next.
So the next talk is going to be by Dr. Nikhil Khattar, and he is going to talk about mainly the leak point pressure and EMG. Over to you, Nikhil.
Hello, can you see my screen? Hello, good evening, everybody.
Yes, Nikhil, is it supposed to be wobbly like this? We are not seeing a straight. Yeah, you need to go on the slideshow. Perfect. Please go ahead.
All right, so good evening, everyone, and thank you for this opportunity. So, talking of leak point pressures, I'll be discussing both of them one by one. First of all, the abdominal leak point pressure, which is the lowest value of an intentionally increased intravesical pressure, which provokes urinary uh, leak in the absence of a detrusor contraction. It can be elicited by either a cuff or a Valsalva, and multiple estimates at fixed bladder volume between 200 to 300 cc should generally be done. And so each word here is very important. It is the lowest value of an intentionally increased intravesical pressure that provokes leak in absence of detrusor contraction. There are some prerequisites, definitely, that all the catheters uh, before we make the patient increase the pressure, all the catheters should be uh, representative of the pressure. The pressure should be really representative. Here we can see that although the patient has made a Valsalva maneuver here, but this is not a reliable thing, because although there is leak, but this P abt is not giving actual pressures here. So it should be something like this, that the tower should be equal whenever we try to elicit the leak. And secondly, here you can, the patients, this is a long Valsalva, and you can see the leak here. And can somebody try to guess what is the leak point pressure? Uh, so I'll tell you, this is something where Dr. Siddharth just now spent a lot of time. And if you see this now, that this is the Valsalva and this is the leak, what is the difference here? The difference is in zeroing. Here it has been zeroed, everything has been zeroed, and here this is zeroed properly to atmosphere. This is not zeroed to atmosphere. So this is not showing the actual abdominal pressure, whereas this is the ALPP for which are standardized. Then are the cuff and Valsalva leak point same, or they are different? So there has been some work on this, and the difference is that cuff is something acute, and to mark the leak point during cuff is difficult, and generally uh, we err on marking it at its peak, whereas Valsalva is gradual and gives the opportunity to correctly mark the leak point. And straining with Valsalva, there is also another difference. Straining with Valsalva requires pelvic floor relaxation, whereas contrarily, cuff leads to reflex contraction of the levator ani. And thereby, leak points with Valsalva are generally lower than the leak points during cuff. So they are different mechanisms, and although it is not yet established how each one should be uh, interpreted, but mostly they are are taken as almost same till now. Should ALPP be measured without a urethral catheter? Because catheters, the cystometry catheter significantly increases the pressure required to leak, and because of its obstructive effect. And it can occasionally also uh, not allow you to elicit the leak, and so a negative stress test can also be there. So in effect, if you see here, this is urodynamic trace of a lady where uh, we are evaluating her for incontinence. So a single cuff is she is asked to cuff once, no leak. She is asked to cuff multiple times, still no leak. Then we ask her to do Valsalva, and then we start seeing leak here. In this prolonged Valsalva also, she did not leak, and then there is leak here. So the cuff, then Valsalva. Uh, Patients generally find it very difficult to understand what abdominal pressure do Valsalva. So they can be asked to blow in a syringe or a straw, and then sometimes discerning whether she has leaked or not is difficult. So a visible leak from meatus is more reliable than actually catching it on the machine. That depends on how sensitive the machine is, and then also a little gap is there before it falls and gives you a tracing here. So actually, it should be the leak seen from the meatus that is more reliable. And if she is not leaking even with all these maneuvers, then Valsalva should be repeated after removal of urethral catheter, where you have already established that she is not having any detrusor overactivity and purely that is stress incontinence. Then you can remove the urethral catheter and again make her do the Valsalva maneuver, so that the rectal pressures, that is the abdominal pressures, are measured and you can get the leak point. But what is the importance is because less than 60 centimeters is considered IST. Although how the decision making is going, how that will change your decision, whether what surgery to do, the prognostication, all that is a different matter. That is not for this lecture. But here we can see that why zeroing is important, because these are the standardized. This is what we want to know, whether the pressure is in the ISD range or not in the ISD range. And if we measure without zeroing to atmosphere, then we'll getting the values which are not standardized. So that is all about ALPP. Now TLPP, the detrusor leak point pressure, which is the lowest value of detrusor pressure at which leakage is observed in the absence of any increased abdominal pressure or detrusor contraction. So here the patient is leaking. One thing is that we should be, both of them are problems of the storage phase. Only patients who have history of incontinence, then only we should be eliciting all these pressures. So in this patient, if the patient has leaked here, this is not DLPP. This is during a detrusor contraction. Although patient had a poor compliance, but the leak happened during a detrusor contraction. This is not a detrusor leak point pressure. This is another leak point pressure nowadays called as detrusor overactivity leak point pressure, but this is not actual DLPP. And similarly here, this is also many a times, if a technician does it, or then you find that this is machine, or sometimes the machine also marks it as DLPP, but it is not. Here, if we see, although this is poor compliance with a compound detrusor overactivity, but once these overactivity were identified, the filling was slowed, we again saw that the pressure is rising here, and then leak starts happening. It's So this is this measure this is DLPP. Then urodynamic methodology may influence the compliance and hence the leak point pressure. The fill rates, if they are too high, that can induce a false poor compliance, and then the DLPP that you get may be different. So if you are suspecting that, then according to the bladder diary or CIC diary, whatever is the predicted capacity, you should keep your fill rates to 5 to 10% and go slowly. And again, to wait for leak to show up on machine is less reliable than confirmation on the meatus, because that avoids delay due to seepage in patient's sheets. Then cutoff of the detrusor leak point pressure for upper tract damage. This 40 centimeter cutoff has been challenged recently, and especially in children. Now we know that sustained pressures of more than 20 centimeter during filling phase may predispose to upper tract damage, and hence overall context gives a better guidance whether upper tract damage is a possibility or not, rather than a single cutoff. If we just a moment. Is this visible to you?
Yes, it is.
Okay, so this is a poor compliance bladder, and although the patient did not leak, but I have marked hypothetically that this is where the patient leaked. So this is exactly the detrusor leak point pressure, which is close to I think around
It's about
30.
30 centimeters. Yeah.
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 So the context where uh, will this be a safe bladder or an unsafe bladder? This patient is does his CIC when he starts getting wet. This trigger now the DLPP importance of DLPP can be used when actually to tell the patient when it is safe to empty the bladder. So this is not a safe thing uh, for him, because he is now in high pressure zone, and this high pressure zone has been from 377 to around 430 440 cc. And if at all he is voiding on his own, and this patient voids on his own, when he starts getting wet, he goes and passes urine by Valsalva, and comes back with a residual of 200 ml. So now he does not even ever go in this zone. He always remains in this zone. So if he is persistently remaining is in such higher pressures, because at the end of his Valsalva voiding, he was left with 200 to 250 cc, and then from here he goes to here. So he is persistently in high zone. So he is not safe at all. Even more unsafe than using CIC as a trigger. So if he uses CIC as a trigger, then he will have more prolonged safe phase. And then if say this patient leaks at this point here and is able to empty completely on spontaneous voiding, he will have more longer run in the safer zone. I don't know. Am I this is the importance of leak point pressure, how, especially in patients who are on CIC, how to communicate them when you are going in unsafe zones. All right. Now, that is all about the leak point pressures. I have not made many slides about EMG, that the ways needle electrode and surface electrode ma'am shared in the beginning. And this is main role of EMG is to whether there is guarding reflex during detrusor overactivity, that can be seen very well. And then during the voiding phase, what is having what is going on, whether there is synergia or dyssynergia. So this is a neurogenic bladder patient, and this is detrusor dyssynergia. Then this, and there is again dyssynergia, which is more clearly seen on the voiding film. But at the same time, this also shows dyssynergia, but this is a patient of benign prostatic obstruction. We can see that the level is not external sphincter, and patient was treated with a BPH means TURP surgery. So EMG, although but it is not very reliable. At times it can give it can lead to false interpretations. So that is all that I have to say. Thank you so much.
Yeah. Thank you, Nikhil. Thank you so much. Well done. Pretty clear. We have some discussion at the end of the session anyway. So let's have more brainstorming on this point of leak point pressure, EMG, and so on at the time of discussion. Let's move on to the next, Anita.
That is
Swarnendu?
Swarnendu, who's going to tell us about troubleshooting. Over to you, Swarnendu. He sent his apology because he's down with viral fever and he's actually got a voiceover, though he's attending. We can see him there.
Generated using
Okay.
AI. We have also included some real graphs and some real videos for the better understanding. As we know, the UDS is an invasive procedure and it dictates the treatment pathway. Hence, there should be a minimal to none artifact which can confound or even mask the diagnosis or an actual problem.
Can you hear him? We can't hear him, sir. Yeah. Yeah. Is the audio working?
No, we can't hear Swarnendu's voice. Swarnendu?
Samantha, can you?
Yes, Swarnendu, we're not able to hear your voice.
Of the pubic symphysis.
Yeah.
And the catheter placement for a vesical catheter, which is inside the bladder, for a female, it should be 8 to 10 centimeter inside, and for a male, it should be 8 centimeter plus the length of the penis. For abdominal pressure catheter, during urodynamics, we should place it inside the rectum. In the females, we can do a PV and look for the catheter while placing inside the rectum. It should be ideally 10 to 15 centimeter length. Should be inside the rectum. If the patient doesn't have a rectum, in a female, you can also place it inside the vagina, which will show similar abdominal pressure tracings. For a vaginal placement, it should be 8 to 10 centimeter. For a male, 10 to 15 centimeter inside the rectum. If the patient doesn't have a rectum, also if she doesn't have a vagina, then you can place the catheter inside the loop or a stoma. If she has a stoma, then the stoma can also give a similar reading of abdominal pressures. The effect of air inside the system. In India, we use the fluid system in the UDS. Air inside a fluid is bad. It will lead to a pressure dampening or a delayed or a poor transmission. Hence, there should not be any air. If there is a bubble, the quick fix is always flush the catheter. Next, coming to once the UDS is set up, we should zero the pressures. This zeroing should not be done to a patient Instead, we should do it to an atmosphere. That is, open the transducer and keep it at the level of pubic symphysis. Then do a zeroing in the machine. So PVS and P abdomen, they both will show a flat line. Then once they show a flat line, you ask the patient to cough. If both are equally tracing upwards with a similar spike, then start the investigation. Criteria for a good quality control of a pressure recordings on a resting values for abdominal and intravesical pressures are in a typical range. When the patient is in supine, it should be in the 5 to 20 centimeter of water. If the patient is sitting, 15 to 40 centimeter of water. And if the patient is standing, then it should be 30 to 50 centimeter of water. If it is out before giving a command to void, you should do one more cuff test to look for the integrity of the and placement of catheter inside. Then ask the patient to void. After voiding, you again ask the patient to cough. So this rules out if the patient has extruded the catheter during straining, then it which keeps the PDET at 0 level. This is a good quality cystometric UDS tracing. As the patient changes their position, the pressure also changes as we discussed. During supine, from supine during standing, the pressure keeps rising. Also from supine to seating, the pressure rises. This will be reflected both in PVS and also P abdomen. Video which suggests that as we see here, the cuff reflex has been given. Both are rising equally, and as the patient from supine to sitting, the pressures are rising, and as the patient stands up, the pressures are rising more, and when the patient gets supine, the pressures coming to a supine level. Then we do a cuff test to look for the integrity. The anatomy of a perfect cuff test is that PVS and P abdomen both are rising equally and keeping the PDET at 0. Here, good cuff response, PVS equals the P abdomen. Whenever the patient coughs, it means that whenever the patient coughs, the tracing of the PVS and the tracing of the P abdomen should be equal, so that the PDET should be always remain 0. Then only you start doing the proceed with your UDS. If it is not coming to 0, or if one of the tracer is not spiking, then there could be a occlusion. As we see here, P abdomen is spiking here, but here PVS should have been spiked equally, but it's not spiking up. It means the PVS catheter or a PVS transducer is occluded. So here we flush. This is the flushing artifact here, spike. Once we flush, then we ask the patient to cough. Both are tracing equally upwards and coming to baseline equally. This is a good cough test and also flush test. When we start UDS, we look at PVS and P abdomen. They both should be equal, so the P test should be 0. If both are not equal, yeah, as we see here, PVS is 19 and the P abdomen is slightly higher than the PVS. This means that the P abdomen, the rectal catheter, is not inside not placed properly. It can be placed too deep, which can lead to this apparent high in the P abdomen. So you pull the catheter 2 centimeter and away from the pocket of a stool. Then again flush the catheter to take out any artifact. Then again give a cuff reflex, and they both P abdomen should be equal to PVS. When the PVS and P abdominal cuff spikes are at different heights, as we see here, the black color line suggests the P abdominal pressure, and the PVS is given by blue tracing. The blue tracing is not equal as the black tracing. There are different spikes. This baseline mismatch between the P abdomen and P det suggests that there is a poor transmission or there is a catheter related artifact. This can be overcome by flushing the catheter. This blue spike here, huge spike, is flushing artifact. Once we flush it, then the tracer should be ideally shows equal rise, as we see in the green line here. The P abdomen and the PVS are of almost equal rise. This is the real-time video where during the cuffing, the P abdomen and the P vest, tracing and the P abdomen are of unequal length. As you see here, it is slightly overshooting. Hence, we flush the catheter here. The P vest is undershooting and the P abdomen is overshooting. Once we flush, they both are equally rising up. Then we come to gradual pressure drift. As we see here, P abdomen is supposed to be in this baseline. As it drifts downward, as it dips, this is called drifting, pressure drifting. This is most likely there is a leakage inside the system, either the tube leak or there will be micro leaks, which should be, this suggests that, so you go there and you also fix the leaks there. This is a real-time video where the P abdominal pressure tracing, as the tracer goes forward, there is a leak. As the leak happens, there is a fall or a drift inside the transmission that leads to a falling of pressure. Whenever you see there is a slow drifting inside the UDS tracing, it should alert you to check for the leaks. When the P vest or a P abdomen drops suddenly, then it is most likely due to catheter extrusion. The catheter has come out from the P abdomen rectum or a P vest from the urethra. Look for the catheter and reposition the catheter. Whenever there is a loss of live signal, there is a sudden flattening of a pressure tracer that indicates there is a lost live signal from occlusion or a bubble. A quick fix here would be a water flush. If there is a physical occlusion, then you have to take out the occlusion. This video, here there is a cuff reflex. Once the cuff reflex, till here, both the catheter intact, both are showing equal tracing, equal upward spikes, suggesting good cuff reflex and good transmission. As we go forward, here there's a dip in the P vest. This is most likely due to catheter coming out of the urethra. The fix would be place the catheter inside the urethra again as 8 to 10 centimeter inside this massive noise in the P abdomen tracer shows that there is a physical occlusion, as patient may be lying down with the catheter trapped with their legs. Then this would lead to a massive noise spiking. Then as the occlusion becomes fully occluded, there will be a loss of signal leading to a flat line. As we see here, there is a massive noise here because of the physical occlusion. Then loss of signal with a flat dead line. So the fix here would be ask the patient, or you look for a catheter entrapment and free the catheter or a transducer. These are the summary slides of whatever we have discussed so far. Symptom: if there is a sudden massive downward drop in the pressure reading on a single line, then likely that catheter has come out. Fix is place the catheter inside the system again. If there is a gradual fall, that is drifting, then look for the leak and fix the leak. If there is a dampening, that means both P abdomen and P vest both are not equally spiking on a curve, that is sluggish waveform, then there might be air bubbles trapped inside the line. The quick fix would be flush the catheter. If the tracing is completely flat, especially after the noise, then it is a physical occlusion. You free the catheter or a transducer. Now coming to a physiology. Here we see P that is spiking up and the P abdomen is dipping. This most likely due to when the patient relaxes their pelvic muscles, it leads to a drop inside the abdominal pressure that lead to a dipping inside in the tracing. This is physiological and you can manually correct this with the subtraction. When you accidentally place a catheter inside the vagina instead of urethra in a females. Then the vaginal catheter, which is supposed to be showing a bladder vesicular pressure, will show abdominal pressure. Then PVS will show a similar tracing to P abdomen. If both are similar, then you should look for the catheter placement if they are fully inside the bladder or inside the vagina. If it's inside the vagina, take out the catheter and place it inside the bladder. This is a real-time image or a graph which shows the same thing. The catheter in a females, especially, as we know, the catheter used in the UDS are around 6 French and ureteric diameter is around of 8 mm, where the 6 French can easily go sometimes. If you place the catheter inside the ureter, P vesical catheter, the PVS can show a spike. These spikes are ureteral peristalsis spike, as we see here. It shows small spikes without rising up corresponding abdominal spikes, and it's most likely due to peristalsis of a ureter, which is transmitted through the catheter inside the ureter. Take out the catheter and place it inside the bladder. Now coming to machine artifacts, whenever you see huge spike of Qmax, that is most likely artifact. Either there will be n number of causes for this. For this, you are either fix is that human interaction, where you go, you either look for an average of a Qmax or you look for a other Qmax which is likely due to a patient voiding. Pump vibration artifacts, as we see P abdomen and also P vex, then showing a lot of massive noise here with a constant noise, and both the noise are equally reflecting. This is due to a pump artifaction. As we increase the flow inside the pump starts vibrating. This vibration is transmitted to the through the transducer. Then it will show on a tracing. These are oscillation instead of regular spikes. This can be overcome by simply slowing down the flow or stopping the pump altogether. Now, quick recap. Whenever you see a pressure out of range, that is whatever the desired range, if it is outside that, then that is most likely due to there is a mismatch in the transducer height, or you have missed the zeroing to the atmosphere. You look for the catheter height level, whether are actually the trays are at the upper border of the pubic symphysis. If they are at the upper border of pubic symphysis, then you look for the zeroing. If it is not zeroed, you open the catheter at atmosphere and zero it. If there is unequal resting pressure between P abdomen and P vesicle, then most likely the catheter is not positioned correctly inside the urethra or the rectum. You look for the catheter and place it accordingly. If there is a poor transmission, it is most likely due to empty bladder. You fill the bladder with the 50 ml, then look for the spike and the transmission again. There is a gradual drifting, and it is most likely there is a leak inside the system. Look for the micro leaks and correct them. If there is a sharp erratic pressure spike, this is known as noise, and then subsequently there is a dead flat line, then it most likely a physical occlusion. If there is complete signal loss with a flat line, then it can be a tubal occlusion or a patient occlusion. Both can be overcome by freeing the catheter and flushing the catheter. Now, physiological artifacts, as we know, rectum contracts. The rectum contracts will be shown by regular spikes of almost equal height. This will be reflected in the P det as a negative spikes. When the pelvic floor relaxes, P abdomen dips and the P det spikes. And when you place the UDS PVS catheter inside the ureter, then there will be a peristaltic artifacts. Now coming to a last and final slide of troubleshooting algorithm. Whenever there is a poor transmission or abnormal resting pressure, when you start the UDS, PVS and P abdomen both are not equal. Then look for the height of the transducer and the placement of catheter. then do the zeroing to the atmosphere. If it resolves, okay. If it doesn't resolve, then flush the affected line, whatever the blue or the red line. If it resolves, then fine. If it is not resolving on this also, then you go for a visual inspection, check for the micro leaks, kinks or a tap, then fix them. If it is still not resolving, and if the PVS is still not showing good transmission, then instill 50 ml of water inside the bladder to free the transducer from the occlusion of the bladder wall. If it resolves, then it continue. Otherwise, then go for then it most likely there is a default in the catheter or a transducer. Change the catheter or a transducer. If there is an abdominal issue, reduce the balloon pressure, or you pull out the catheter from the rectum 2 centimeter. If it resolves, okay. If it is not resolving on this also, then it means there is a catheter or a transducer artifact or a damaged one, or you are using a old one. You change it and try the UDS again. The 3 golden rules: always question the baseline. Cuff tests are mandatory. Ask them to cuff every 1 minute before voiding and after voiding during flowmetry. And treat the patient, not the trace. Always correlate with your knowledge and the patient history.
Thank you, I'm done. Thank you.
Thank you, Swarnendu. That was exhaustive, very nicely done. We will straight away move to the last and a very important presentation today, and that is actually showing how we do a good pressure flow study. And may I request Dr. Shirish to share his screen. Over to you, Dr. Yande.
Sure. Thank you so much, Anita. Here we go. Since I spoke to Anita last time, I thought I would go to now whenever it is here, I would go directly to a video, a pre-recorded video, and that's the one. Can you, yeah, share. Okay. Now what I'll do is I'll turn off the volume. Yeah, am I heard now?
Yes, we can.
Okay, I'll turn off this volume completely. So basically, there could be some repetition because we have to get. There is a. This is a proper interrogation of the patient where all reports are checked, including a bladder diary, which is properly reviewed as a part of your urodynamic workup, and then at the end of all that we generate urodynamic questions and a working diagnosis. What could be the urodynamic questions we want to generate? Well, is the bladder outlet obstructed, for instance, or what is the precise mechanism of incontinence? The thing would be, is this bladder safe for upper urinary tracts, or is this suitable for a renal transplant? Or for that matter, what is the possible outcome of surgery? So after India, it's nice to have a quick bladder scan to check the residual volume. And while we are doing this, our technician is busy readying the equipment. He's checking the transducers. And it's always our practice to make sure that we do a quick check on the quality control at the beginning of all the studies. And this is I think is very important aspect. These are the infusion pump and tubes and so on. The pressure recorded by electronic pressure transducers. And whatever analog signals are produced by the transducer are converted into digital signals by our equipment, and this can be projected in the desired fashion on the monitor. Well, that's perfectly fine. I'm just going to show you a quick one. We would do all theater asepsis normally, mobilize, lubricate the urethra properly, and then go in. I usually use 2 catheters, but you can use a double lumen catheter. But then when you insert 2 catheters, we piggyback the small one into the infusion catheter, insert into the bladder, and then as soon as you enter the bladder, you disconnect them and advance each catheter individually to the desired length. It does the proper job. Alternatively, you can use a biolumin catheter, which is perfectly fine. It allows you to do repeat urodynamic studies on several occasions. In this case, I'm using a 6 French biolumin catheter in the male, and then we have the prompting the equipment. We will take away all the air bubbles, connect it back to the pressure transducer. While we are putting in a rectal catheter, it always gives an opportunity of a quick check of a sacral reflex arc in all these patients. Zeroing has been discussed several times today. Basically, what all of us need to understand is the baseline is transducer must be brought to the horizontal level of the upper margin of pubis for standardization and zero to the atmosphere. This is just to show how the transducer brought to the level of the pubis in every case at the beginning of the study. There are various ways of zeroing the pressure lines. One of the ways that we have been using more repeatedly is use a three-way adapter, and then you can have the water-filled lines already connected, and then turn the three-way tap in such a way that they are open to atmosphere and then brought to the patient's pubis level, and then you zero the one. And after that, you turn the three-way tap in such a way that now connected to the patient, the bladder and the rectum. Whatever way you do the zeroing, it must make sure that the signals are correctly recorded, pressure lines are perfectly in line, and there are no air bubbles, and there is a fairly good transmission of pressure and a good subtraction of abdominal pressure from the intravesical pressure in all the cases all the time. And that's has been emphasized several times in today's session. What we basically know is avoiding cystometry. Coming to avoiding cystometry, well, it's a method by which pressure for relationship of the bladder and urethra is established at every point of time during the voiding phase of micturition. So a patient is generally, after being has a normal desire to void, is allowed to void in the position that he's normally used to, and on the pressure and the flow is synchronously measured. What is a pressure flow study really? Pressure flow study really is an interactive process of pressure and flow at the same time, influenced by force of detrusor contraction and outlet resistance at every point of time during the voiding cycle, so that detrusor pressure becomes a response of detrusor contractility as well as the outlet resistance at every point of time. This is one of my favorite animation. The detrusor contraction force, which we do not measure, urethral resistance that we do not measure. What we measure is detrusor pressure as a result of these two forces. Then there is a flow, which is difference between detrusor pressure and the urethral resistance. Another parameter which you do not measure is bladder volume, which I think needs to be measured, and ultimately flow rate is a resultant of all the forces together. So this is generally the dynamics of a pressure flow. Basically, voiding cycle is a complex interaction of various forces which we understand and some of which we measure as parameters. Now, this is quick examples. What we measure by this orientation, infusion line. Then there is intravesical pressure as measured by catheter into the bladder. Then there is a rectal pressure, that abdominal pressure is measured by catheter in the rectum. Our fourth channel is the subtracted detrusor pressure. This is the uroflow. This is the voided volume, and finally EMG, which we do basically in all our cases. We do EMG in all the cases. Now, just to give you a quick example, a quick check of the quality control. At the beginning of the study, you must make sure that all the pressure lines are close to zero, but at the positive side of zero. Second thing to check is, are the signals correctly received and subtracted by the equipment, and that is again a quick check. There's before voiding and after voiding. So now we can be ready to interpret this urodynamic stress, the bladder is storing pressure, storing saline at a very low pressure. Change of patient's position has led to changes in the intravesical and abdominal pressure. There's no change in detrusor pressure, you can see, and patient may have had a slightly larger volume of infusion. But when you come to voiding study, I just expand it for you for us to understand, and you find that again a quick pressure check, good subtraction before voiding, good subtraction after voiding. So whatever is recorded between these 2 points must be acceptable as a good quality for interpretation. And now you see that the first instance is that there's a complete silence on the EMG, which represents a good relaxation of the pelvic floor while the permission to void is given. This is where the bladder starts generating pressure, and a point at this is where the point at which the flow starts. Why is PDAT QMAC, why is QMAC so important? And I will discuss it as we go along. But then this is the entire pressure flow study. The blood, if the detrusor pressure stays around 30 centimeters of water, the flow stays around 70 mm per second. So these are reasonably normal values for adult male. This was a 54-year-old male who has a lot of storage symptoms which we could not produce at the time of investigation. But I'm just gave you an example of what a normal pressure flow would look like. On the other hand, there is another gentleman here, a 68-year-old man who essentially had voiding LUTS for a long time. His uroflowmetry showed a small volume, but 11 mL per second, which by any standards we will call it as a low flow rate. Let us see what his pressure flow showed, because he was essentially referred for pressure flow study. And this is what we have got. Again, a quick check at the quality shows a good subtraction before and good subtraction before and after voiding. What it shows basically that again a low pressure storage, there is overactivity there, which does produce bit of urgency, but if no incontinence, so possibly is not of a great clinical consequence. When you come to the voiding phase, I'll just expand it for you. Again, a quality check. The coughing before and coughing after seems to be reasonably good. So now we try and analyze this pressure flow study. What has happened here is that the flow begins at a fairly high pressure, 60 centimeters of water. This is my interpretation of detrusor response to a narrowed outlet, and therefore detrusor may not be contracting more powerfully, but the generated pressure is high, and so PDAT QMAX shows to be 60. Here the flow rate was 8 mL per second, and the entire pressure flow, entire voiding occurs at a fairly high pressure, producing a low flow. So this can be regarded as a bladder outlet obstruction with a reasonably normal detrusor contractility in terms of amplitude as well as sustenance. So this is what I would qualify this particular recording as. As against that, we can also go to ICS, and ICS, if you subject these values to ICS, it will show you that it is an obstructed zone, but also shows a normal detrusor contractility, which is reasonably normal. I will move to the next case quickly. This gentleman is a 64-year-old diabetic for 12 years, had progressive voiding LUTS, particularly straining to void towards the end of voiding, and his uroflow does seem to represent a little bit of a straining pattern in the later phase of his voiding. Let us see what his pressure flow shows. And we have done a quality check. All right, now let us see what it shows. He has a fairly large volume infused. It's a hyposensitive, large capacity bladder, mild overactivity, but producing mild urgency but no other consequence. Come back to the voiding, and again the voiding phase. Let me expand this phase for you and see. Subtraction seems to be pretty good. All right, expand it for voiding and then analyze, and here we find that the detrusor pressure remains fairly low, 30 or below that. If you can notice very carefully, the rectal pressure has fallen. All right, and this is because of the relaxation of the pelvic floor muscles, and therefore the bladder pressure, the detrusor pressure is recorded to be slightly higher, so it should be lower than it is actually shown here. So anyway, the low pressure and producing low flow generally goes in favor of detrusor underactivity, probably consistent with diabetic neuropathy qualified as diabetic cystopathy. I'll just give you one more example. You could have young man coming with widening LUTs, seems to have a fairly normal filling phase, particularly, but he has a bit of a poor compliance at the end, but that's okay. When it comes to voiding, I want you to look at is that the voiding phase shows straining pattern. Then there is a pressure flow is paradoxical, is a 45 centimeters producing flow of 5, which seems to be okay, but as the flow progresses, the flow falls but the pressure rises, and this is a paradoxical pressure flow relationship you often come across, particularly in these kind of individuals. And this probably says you that there is an outlet which is dynamically obstructive, and this could actually suggest a voiding dysfunction because of pelvic floor or a sphincter dysfunction, and the sphincter tends to stay less contracted or less relaxed during voiding, and that is why you may get a paradoxical pressure flow relationship. This gives you a fairly good suggestion they're dealing with some kind of pelvic floor dysfunction, some kind of sphincter dysfunction, producing this voiding symptoms. So this is just to give you an idea as to how pressure flow can actually be projected. But remember that pressure flow is a dynamic interaction between detrusor pressure and uroflow, essentially uh, essentially presented by force of detrusor contraction and outlet resistance at every point of time. So bladder outlet obstruction, detrusor rector are not the only things. What's important is pressure flow gives you is precise interpretation of detrusor function and the outlet status. Thank you so much.
Thank you so much, Shirish. That was extremely well done. And there are some questions. There's one question which is asking about normal pressures for an adult male, for an adult female, and for a child, to which I have replied, and has Siddharth has also replied. I probably disagree with Siddharth a bit. For an adult male, 40 to 60 would be my range, and anything more than that, I would be not very comfortable. For a female, less than 20 centimeters. Having said
Ma'am,
that, many women,
so
I'll just complete Siddharth. So many women will pass urine at zero pressure also, who will be perfectly normal because they pass urine by relaxing the outlet rather than by using detrusor pump. So anything which is 20 or below should be fine for a female. For a child, again, there wouldn't be a fixed figure, as I mentioned, for the reasons that I have mentioned. Sorry, Siddharth, you could go ahead now.
no, sorry, I get your point totally. But ma'am, 40 is a borderline for underactivity. So
Yeah,
I
so
whatever
about
normal
40 to 60 is where I would place it. I
okay.
totally agree. 80 in my books would be high for a male, but
Uh, no, because average male, if you calculate voids by 25 ml per second, like an average good flow for a healthy young male. So if you
yeah.
calculate the bladder outlet index with 80 also, it will come to 20 or 30. P dot Qmax minus 2 Qmax. So still not obstructed. I'm not saying 80 is high normal, but 60 is average because below 60 it goes into a category where patient is having low bladder contractility index. So it is going to obstruct underactivity.
So sure,
Siddharth,
below 40 it does.
Hmm.
Below 40 it does.
Siddharth, I beg to differ. Let me tell you, my experience tells me, see, pressure and flow must be taken together. You can't
Yes,
just say 30
true,
and 50.
true.
I take 30 to 50 in adult male simply because I would like to compare it with the flow at that particular time, QMax, for example, and we see that. So I think they must be taken together. You cannot take as pressure as a isolated parameter to diagnose an outlet. So we have to take it. That's number one. Number two is Anita said that women void by pelvic for relaxation. Well, women void also by detrusor contraction, except that detrusor contraction must be registered by the catheter into the bladder, and if the urine is exiting too fast, the bladder is not allowed to generate the intraluminal pressure, and we feel that bladder isn't contracting. Yes, bladder is contracting, but it's just that intraluminal pressure remains so low because of urine leaving very fast, and that is exactly the dynamics of voiding, which we all need to understand in interpreting any pressure flow study.
Yeah, I do agree about that, and which is why defining underactive detrusor in a female is a very tricky affair.
Absolutely,
It's
very difficult
easy
to
to
do.
define obstruction, so
Very, very
anybody who's
difficult.
more than 20,
Yeah,
of course, match that with the flow,
yeah, yeah.
but that would be obstruction. And as Siddharth made it very, very clear that the PQ plot is designed not for a child, not for a female, but for an adult male.
That's
And it
right.
should never be applied,
Yeah,
the standard PQ plot, either to a child or to a
that's
female.
right.
So,
And sometimes you are not able to demonstrate an obstruction of pressure flow. Go back to the filling phase. Filling phase is not an ideal way, but if you can show a patient leaks at a pressure of less than 30 centimeters, he probably is not obstructed at all. There is no mechanical obstruction in his bladder. But that's a different question. We can that could be debatable also. But that is what I feel anyway. So let's go to the other questions.
I was just going to throw a question. What are the tricks used by all the faculty here for measuring pressure through the colostomy? We do UDS for many children and for adults who may have had anteroposterior resection and then are there with a colostomy, and there can be artifacts. So, are there any tricks that any one of you follows to ensure that correct pressure transmission is possible? Siddharth, since you were covering voiding cystometry, I thought I'll just check
Yes,
with
ma'am.
you.
So, very few cases I have done where I needed to use, like a patient needing urodynamics and a colostomy. So, definitely there are a lot of artifacts of rectal, like bowel contractions, which come in. But what I feel is that when patient is, you put a vesical catheter anyways, and patient generates a good void, a sustained contraction gives you a very good idea whether the patient has obstruction or a good contraction. And if there is a little rectal drop in that process, it can be correlated with the drop in the abdominal trace, which should be more vigilant. But I feel like just a vesical trace can also give you a lot of ideas. You never, not necessarily always need an abdominal trace in such setting.
Yeah, that's a valid point. And also, I think before placing the catheter in the colostomy, with a finger, gently check which way the colostomy is going,
Yeah.
because it's obviously the stools are coming out of that colostomy, so your finger is not going to do any damage. And then guide the catheter correctly, and then read the vesical pressure intelligently. These are the two, three things which I tend to follow because it can be quite tricky to use a colostomy
But
catheter for
Anita,
pressure
I
measurement.
don't find any difference in using colostomy or rectal catheters. I mean,
No, there is no difference. It's just how to place it correctly
correct, correct.
because there is constant waves going on,
That's right.
Shirish, which is not going on in the rectum. Okay. A transverse colostomy or a high colostomy, there is continuous waves going on, and
That's
there
right.
is a tendency for the catheter to get pushed out. So I actually make an assistant to hold the catheter in place
Correct.
because otherwise, in our enthusiasm to measure everything, we may not even realize that the tube is slipping out.
Sure. Make sure it goes well
Yeah.
in and say
Yeah.
beyond the abdominal wall.
Another question I would like to ask is to Nikhil. So, Nikhil, in your cough or Valsalva leak point pressure, do you always have a flow meter between the patient's legs?
At times when it is difficult, And if she's not passing, means not we are not able to elicit the leak. We make the patient stand with her legs apart and then visualize the meatus and make her cough. So it is as I also told. No, I did not say this, but yes.
Yeah, what I
Then
also tend to
Euroflowmeter
do, yeah.
won't be.
Yeah, the uroflowmetry actually makes the patients spread their legs abnormally, and many normal women may actually find it very difficult to control a leak in that position. But instead of a flow meter, if you could have a green sheet. Why green? Because a little drop also falling on that, it's very easy. You can make it out very easily. And of course, be vigilant to look at a little trickle by the side or along the thigh. But to get her to leak precisely on a flow meter can be a challenge. And if you make the female spread the legs so much, sometimes the rectal catheter can slip out also. And that catheter is so important for doing the cough leak point pressure. So, one of the things that I tend to do is to have a green sheet and not necessarily have a flow meter. Though flow meter gives a nice little bump in the curve to show, you can actually quantify. But that's just one of the tricks.
Yeah.
Nikhil mentioned that we can use rectal pressure to diagnose
Yes.
ALPP. Yeah, and that's perfectly fine. I think as long
No,
as you can
I
clear
mentioned that we can remove the urethral
overactivity.
catheter
Yes, we
and
always
and
measure rectal
smear
pressure.
it.
Yeah.
Yes. Yes. No discussion about that. Yes. Yes.
I mean, removing the intravesical catheter, and as long as we are satisfied the patient has no detrusor overactivity, then you can use rectal catheter, rectal pressure to measure the ALPP without a urethral catheter, and that maybe give you a better, a more accurate measurement.
And also in olden times, very often a detailed filling cystometry was not necessarily done in a patient who was being subjected to cough leak point. And which is why they were very fussy about having vesicle line. But as Shirish has very rightly said, once you've ruled out overactivity, especially cough-induced overactivity,
Correct.
then having that vesicle line doesn't give you any advantage. You're
Absolutely.
primarily interested in measuring cough.
Particularly when you don't demonstrate leakage with the
Yep.
catheter in.
Yes, yes, yes. And my last question to Siddharth. So, do you use a video in each and every patient, Siddharth?
Yes, ma'am.
I
We
was a
have been.
little
Um,
impressed and a little
I know.
surprised.
Yes, yes. I will tell you. Basically, when I was a resident at my institute, there was no video aerodynamics. We did a standard aerodynamics. But in my fellowship training in US, I learned only video aerodynamics for every case. Even I had a question: why to fluoroscreen? Why to put contrast? Why to do this? But actually, I realized that video gives a lot of information which you might miss in the trace. Means sometimes I have seen people who will label a bladder impaired compliant just on the trace, but the bladder is beautifully smoothly outlined. First thing. Secondly, any voiding dysfunction, either male or female, especially female, how you can say it is PPNO or dysfunctional voiding or whatever without having a fluoroscopic image. So we started doing video for every case, not only for the perspective of diagnosing, but also resident learning. And I would say you can diagnose so many things by doing video. You can see the bladder outline, you can see the reflux, you can see the bladder neck, how it is opening in a simultaneous fashion, which is the most important factor. Because suppose you do a urodynamic study for a female and patient is obstructed. Now what? Where is the obstruction? You do a MCU later on. Now MCU patient voids, not voids, or opens the bladder neck, doesn't open the bladder neck, but you don't know whether that point in time patient generated a contraction or not. But here with the video aerodynamics, you have a synchronicity of both the things, which gives you the confidence to go ahead and treat it. And that is how we started doing BNI and BNR for female PPNO, which we have done like around 40, 50
That's
cases with
perfectly
good
fine.
results. Never had a problem, especially because we were doing VUDS. Just doing UDS, you will never have the
Very
confidence to cut a bladder neck.
So, I think my question was quite precise. All of us in principle agree with every line that you said. My question was, do you need a video in every UDS? And in my
No,
books, I think the
no.
indications are very selected, and all the indications you mentioned, all of us would be in agreement that female BNO, dysfunctional voider. I mean, reflux doesn't
Neurogenic
come as a
bladder.
surprise. Reflux doesn't come
Yeah.
as a surprise. Those patients ideally should have had an MCU beforehand anyway. You're not going to suddenly find VUR just because you did a video.
Yes,
But
yes.
in my books, the indications would be if I did 100 patients, I would say 30 of those would need UDS because they have a complex clinical presentation. But I would throw the question open to the remaining faculty. About almost 60% of my patients, I'd be very happy to give the diagnosis even in the absence of a video, provided I use my graphs, pre-UDS information, history, clinical exam, and everything rolled together intelligently. I would love comments from both Nikhil, Shirish, Sarika, whoever.
So, ma'am, I recently started video aerodynamic at my own clinic, and but still, it is only some 20% of or 20 to 30% of the patients. Initially, enthusiastically, I used for every woman, first 5 women I used, 3 of them did not void, and I found that I just wasted contrast and I wasted so next what I did was I made sure by without contrast by doing a simple urodynamic that female voids. If I find that there is obstruction, not underactivity, then only I instilled contrast again and did another cycle. So at times I feel it is not for although for women more important to have video, but definitely not in men who are suspected of having BPH. Their urodynamic question can be very easily answered without a video, unless we are discussing Parkinson's and all
For a
there
primary BNO in a
MSA
young
versus
male, I mean, the
Parkinson's.
only way to diagnose that would be to showing a shut bladder neck in a young patient.
Yes,
Yes.
in
Yes.
young males, definitely. Young males, it will be more like what we do in women. The same criteria apply. Once the prostate goes out of equation, then same criteria.
Right. Right. I'm
So
going
that is
to.
where I'm saying, sir. Sorry, like neurogenic bladder, video aerodynamics is the recommendation of choice. Female, very difficult to diagnose without video. Then young males with any voiding dysfunction, again, video is essential.
Correct.
Only subcategory remaining is BPH patients. BPH patient, majority of men, you don't even need a urodynamics. Truly speaking, if you have a good big prostate, even if it is mild underactivity, of course we do urodynamics in situations. But I feel after doing all the video aerodynamics, I understood that very few I will not do without video aerodynamics. Like on the contrary to you, I will do again if I have to go back. I will do 70 or 80% with video only. I'm sorry.
It's always good to have a difference of opinion.
I have been less and less about a higher threshold actually for video now. I used to do a lot of videos before. I'm getting less and less because I find that whatever we want to know, we could know by standard aerodynamics. Again, doing video, particularly paraplegics and so on, can be so messy to give the right position, correct imaging, and so on. Time consuming. At the same time, we may not get an optimum video information. So I think what we do, if we have a complication, if we have a suspicion, we can always do a standalone MCU to have it. But of course, they are not synonymous. But I feel that yes, you have to be. I think one needs to be selective in choosing your videos.
I think we could
One
actually
last
say
point.
that.
One last point I want to say is with the video, the most beautiful thing is you can show the patient what is going on with the bladder. That also teaches her a lot. She can see, oh, I have a dilated
It
urethra.
is
Oh, my bladder
becoming
looks like this.
increasingly more
Gives a lot
important
of
these days.
information there and then
Yes, right.
for
No,
the
we all
patient also.
totally
It's
agree,
becoming
Siddharth.
increasingly
There
important.
is no
No,
discussion.
why I'm
But
saying I'm not trying to prove myself right, but I'm just saying if you have the possibility to start it, you'll start it and you will see how much life becomes easier in diagnosing things.
sure,
Yeah,
sure.
video is excellent.
Video is very cumbersome in situations where you really need it, and very easy to do in patients where it's
Yeah,
probably not making sense.
exactly. And a fit
I'm
young
just
man,
putting it in a
video is
slightly
the
different
easiest thing to do.
perspective. But not to disagree, I do agree that it gives
Microbiology.
huge amount of information when you really need it. I think we could go on discussing this forever, and I am seeing Dr. Surya Prakash jumping up and down because we are about 20 minutes ahead of time.
Surya Prakash, Boogie, the final.
Over to you, Dr. Surya Prakash.
Yeah.
But before that, thank you so much to each and every person who delivered the talk so
Yeah.
eloquently, and everybody summarized exactly what we were expecting them to do. And I hope the webinar will prove to be useful to those who have attended, and also to those who may not have attended today, but will be able to see it later on in our USI education portal. Over to you,
Surya
Dr.
Prakash,
Surya
how many
Prakash.
people logged in? Surya Prakash, can you tell us?
That I don't know as of now, because we are all logging through the faculty.
We are on the faculty link.
link.
So
So
you
I
don't
don't know
know
how
the
many
number.
people.
Will you know
Surprisingly,
it
even
later?
the question link is also there are only two questions. One for Dr. Siddharth about zeroing. I think Dr. Shirish Yanda has nicely shown the video how to zero it. And one comment about the video which was not playing. That's why there are not many questions. I think if Dr. Neeraj wants to give any comments, if he's there.
No. He was busy in a transplant. He sent me a message, which is why I started giving answers to questions and asking the rest of the speakers.
Okay.
He finished the case and could leave the OT just by 8:45. So he sent me a message saying that I got stuck in my OT and I'm so sorry. I wouldn't be able to join. Yeah.
Okay. Thank you, everyone, especially the female and functional urology section of USI. It was really a wonderful webinar. All this is recorded and it is available in the e-learning platform. So my sincere thanks to Dr. Shirish Ande sir, Chairman of FFUS, Dr. Anita Patel, all the speakers, Dr. Nikhil Kattar, Dr. Swarnendu, Dr. Siddharth, Dr. Sarika. Your talks were really, really very good, and I think one should go back and see them if you really want to learn UDS in a perfect way. Thank you so much. And from ISU, I think is Dr. Uttam Mete there.
Thanks everybody. Very nice.
Dr. Uttam sir,
Is Uttam still there? Uttam has left.
He's there.
The busiest man in the business.
Yes. Thank you, everyone.
Anyway, thanks everyone. Thank you.
Thank you, everyone.
It was a real pleasure.
Yes.
Thank you.
With you.
Thank you so much. Thank you.
Okay. Yeah. Can you have a permission to leave?
Yes, sir. Yes.